Bismillahirrahmanirrahim. Today we will discuss anatomy of the pharynx, pharyngitis, and then adenoids. First of all, anatomy of the pharynx. Pharynx is a wide fibromuscular tube situated behind the nose, oral cavity, and larynx. Pharynx is bounded superiorly by the base of the skull, inferiorly lower border of the cricoid cartilage. Posteriorly, it is related to the first, second, third, fourth, up to sixth cervical vertebrae, and anteriorly, the pharynx communicates with the nose, oral cavity, and the larynx. Pharynx can be divided into three parts. Number one is the nasopharynx, second is the oropharynx, and the last one is the hypopharynx. This figure is showing you different parts of the pharynx. The yellowish color area is showing the nasopharynx, whereas the oropharynx is shown by the pink color, whereas the laryngopharynx or hypopharynx is shown by the bluish area. First, we will discuss a brief account of anatomy of the nasopharynx. Nasopharynx is the upper part of the pharynx lying behind the nose. Anteriorly, the nasopharynx is bounded by the choana. Superiorly, it is bounded by the basi-occiput and basi-sphenoid, and inferiorly, it is limited by the upper surface of the soft palate. Nasopharynx is lined by ciliated columnar epithelium. Physiologically, it is part of the upper respiratory tract. It also takes part in phonation. As far as the nerve supply is concerned, the nasopharynx is supplied by the maxillary nerve through the pterygopalatine ganglion. Blood supply, it is supplied by the ascending pharyngeal artery, which is a branch of the external carotid artery. Venous drainage is through the pharyngeal plexus of veins. The important features of the nasopharynx are that in the lateral wall, we have pharyngeal opening of the eustachian tubes. Second, we have fossa of Rosenmuller, and in the roof, we have nasopharyngeal tonsil, which is commonly called adenoids in children. The second part is the oropharynx, which is the middle part of the pharynx behind the oral cavity. Superiorly, the oropharynx is bounded by the undersurface of the soft palate. Anteriorly, it communicates with oral cavity. Inferiorly, it is limited by the hyoid bone, and posteriorly, it is related to the second and third cervical vertebrae. Oropharynx is lined by the stratified squamous epithelium. Physiologically, oropharynx takes part in three important functions. Number one, respiration. Second, regurgitation. Third, phonation. In the lateral wall of the oropharynx, we have palatine tonsils, which are very important structures, which are called palatine tonsil, which when inflamed, the term disease is known as tonsillitis. In anterior wall, oropharynx contains lingual tonsils, and in the posterior wall of the oropharynx, there are scattered lymphoid tissue in the submucosa. Blood supply of the oropharynx comes through tonsillar artery and ascending pharyngeal artery. Venous drainage is through the pharyngeal plexus of veins. As far as the nerve supply is concerned, pharyngeal plexus, which is formed by the 9th and 10th cranial nerves, these serve as nerve supply of the oropharynx. third part is the hypopharynx, which is the lowermost part of the pharynx situated behind the larynx. As far as the boundaries of hypopharynx are concerned, superiorly, the hypopharynx communicates with oropharynx at the level of quiet bone. Inferiorly, it is continuous with the esophagus at the lower border of the cricoid cartilage and at the level of C6 vertebra. Anteriorly, it has laryngeal inlet, arytenoid cartilage, posterior surface of the cricoid cartilage. And posteriorly, the hypopharynx is related to the C4, C5, and C6 cervical vertebrae. That is, the hypopharynx consists of three parts. Number one is the pyriform fossa, second is the posterior pharyngeal wall, and third one is the post-cricoid area. Hypopharynx is lined by stratified squamous epithelium. Physiologically, it takes part in two important functions. Number one, respiration. Secondly, regurgitation. Nerve supply comes through the pharyngeal plexus, which is formed by the 9th and 10th cranial nerves. The blood supply comes from ascending pharyngeal artery and pharyngeal branch of internal maxillary artery. Venous drainage of the hypopharynx is through the venous plexus of veins. Now the layers of the pharyngeal wall. The pharyngeal wall consists of following layers from within outwards. The innermost layer of the pharyngeal wall is the mucosa, which is ciliated columnar epithelium in the nasopharynx and stratified squamous epithelium in the oropharynx and hypopharynx. Outer to the mucosa is the second layer, that is the submucosa. Outer to the submucosa is the pharyngobasilar fascia. The fourth layer is the muscular layer, which consists of two types of layers. Outer longitudinal layer, the inner one is the circular layer of muscles. Outer longitudinal muscles are palatopharyngeus, stylopharyngeus, salpingopharyngeus, whereas the inner circular layer of muscles consists of three important constrictor muscles of the pharynx, that is the superior constrictor muscle, middle constrictor muscle, and the inferior constrictor muscle of the pharynx. The outermost layer is the buccopharyngeal fascia. This is the figure showing the lateral view of the pharynx, showing the different three important parts: nasopharynx, oropharynx, and hypopharynx. This is the posterior aspect of the pharynx. Now we discuss the pharyngitis. The definition of pharyngitis is, it is the inflammation of the mucous membrane lining the pharynx. It can be of two types. It may be acute pharyngitis or it may be chronic pharyngitis. The acute pharyngitis is further subdivided into specific and non-specific acute pharyngitis. Similarly, the chronic pharyngitis can be subdivided into two subtypes. One is the specific, the second one is the non-specific chronic pharyngitis. First, we take up the acute pharyngitis. Acute pharyngitis is the acute inflammation of the mucous membrane lining the pharynx. As far as the etiology of acute pharyngitis is concerned, there are certain predisposing factors in the form of diet, certain inflammations, constitutional disorders, and climate which predispose the pharynx to acute pharyngitis. The dietary factors, for example, preserved food, hot and cold drinks, spicy foods, inflammation such as acute or chronic rhinitis, acute or chronic sinusitis or bronchitis. Similarly, constitutional disorders, for example, if the patient is malnourished, he is having some sort of debilitated disease, diabetes mellitus, and sometimes the climate may play a part as a predisposing factor. For example, extremes of temperature or humidity sometimes may lead to acute pharyngitis. Trauma sometimes may also predispose the pharynx to acute pharyngitis, for example, due to intake of corrosive, surgical trauma, or foreign body trauma. All these may predispose the pharynx to develop the acute pharyngitis. Causative agents, usually the pharyngitis starts first as a viral disease. Later on, the bacteria may jump and they perpetuate the condition. The viruses which are responsible for causing the viral pharyngitis are adenovirus, rhinovirus, coronavirus, influenza type A and type B viruses, parainfluenza viruses, and respiratory syncytial viruses. The bacteria which are commonly seen to involve to cause acute pharyngitis are beta hemolytic streptococci, non-hemolytic streptococci, staphylococci, and H. influenzae. Symptoms of acute pharyngitis. These are malaise, sore throat, fever, and sometimes headache. And if we examine the throat of the patient, there may be hyperemia of the posterior pharyngeal wall. We will see streak of mucopus over the posterior pharyngeal wall, and if we examine the neck for lymph nodes, we may have cervical lymphadenopathy. Sometimes acute pharyngitis may develop certain complications which may be local ones or it may be these may be distant ones. The local complications in the form of sinusitis, acute subpharyngitis media, acute laryngitis, acute tracheobronchitis, and pneumonia sometimes may develop if acute pharyngitis is not treated well in time. The distant complications which may occur may include meningitis, encephalitis, and myocarditis. Treatment is bed rest, analgesics, antibiotics, antibiotics, plenty of fluids, and good nourishing diets and vitamins. Preferably, the patient's throat swab should be taken and it should be sent for culture sensitivity report, and antibiotics are selected according to the culture sensitivity report. Second important disease is the chronic pharyngitis. Chronic pharyngitis is the chronic non-specific inflammation of the pharynx. Usually, this chronic pharyngitis is due to certain other chronic illness in the vicinity. For example, chronic sinusitis, chronic bronchitis, gingivitis, dental caries, smoking, alcoholic drinks, and industrial fumes and chemicals. Symptoms of chronic pharyngitis include sore throat, uneasiness in the throat, feeling of lump in the throat, and repeated urge to clear the throat. And when we examine the throat of these patients having chronic pharyngitis, we may have certain islands of lymphoid tissue on the posterior pharyngeal wall which are hyperemic and enlarged. Treatment for chronic pharyngitis is, first of all, we should look for certain predisposing factor which is responsible for the development of chronic pharyngitis. Then avoid smoking and irritant drinks and spicy foods, and local antiseptic gargles may be prescribed to the patient so that the patient may have soothing effect due to these local antiseptic gargles. Now, please look this photograph. This photograph is the photograph of a child around about 6 to 7 years of age. Then there are certain peculiar features which are evident on the face. Open mouth, prominent upper teeth, triangular face. Another photograph of another patient showing you similar sort of features. These two photographs, they are due to a very important disease in this age group patients, that is the adenoids. Adenoids. Adenoids are actually the enlarged nasopharyngeal tonsils. You know from the anatomy that in the childhood, in the nasopharynx, there is a collection of lymphoid tissue in the costo-superior wall of the nasopharynx. These are, when they are enlarged, they are called adenoids. As far as the etiology of adenoid is concerned, this is due to the repeated infections by gram-positive cocci. This condition is commonly seen in childhood between the age of 6 months to 12 years of age. The peak age incidence is 5 to 6 years of years, that is the school going age, because adenoids undergo spontaneous atrophy in adults. These are not seen in adults because they become atrophic after the age of 12 to 14 years of age. It can be of two types. Adenoids may be acute adenoiditis or it may be chronic adenoiditis. If the patient presents with acute adenoiditis, then the symptoms will be pain behind the nose, he may be having fever, there may be anterior nasal discharge, and sometimes he may be having posterior nasal discharge. And the patient will also have nocturnal cough. In chronic adenoiditis, the patient usually will have mechanical symptoms in the form of nasal obstruction, mouth breathing, dry mouth, difficulty in breastfeeding, snoring. The patient may have conductive deafness due to development of malfunction of the eustachian tube, tubal dysfunction, or conductive deafness due to development of secretory otitis media. The patient sometimes may have toneless speech in the form due to rhinolalia plaza. He may be having cough, and the most typical important feature of chronic adenoiditis is the adenoid faces. In adenoid faces, the child will have a typical picture of his face. That is, he will have open mouth, narrow nose, triangular face, high arch palate, nasal discharge, dull look, pinched nose, prominent upper incisor teeth. All these, they constitute the adenoid faces. Then the patient may have inflammatory symptoms, for example, chronic nasal catarrh, chronic sinusitis. Sometimes he may be having epistaxis and post-nasal as well. There may be some reflex symptoms. These are due to the higher carbon dioxide level in the blood. For example, the baby, the child may have nocturnal enuresis. He may be having convulsions, grinding of teeth, night terrors, and restless due to disturbed sleep at night. Signs in these patients: in the nose, the patient may have nasal discharge, reduced nasal patency, and if we perform posterior anoscopy, if the child is cooperative one, then we may see adenoids in the nasopharynx on performing posterior rhinoscopy. And if we examine the neck for lymph nodes, if the cervical lymph nodes are enlarged and they are tender, then the condition will be termed as acute adenoiditis. On the other hand, if the patient is having chronic adenoids, in that case, the cervical lymph nodes will be enlarged, but they will be non-tender. Investigations, because we have to operate the patient. Therefore, the investigations which are usually done to rule out acute infection. And then we may also ask for X-ray soft tissue nasopharynx lateral view, which may show enlarged adenoids in the nasopharynx. General investigation in the form of complete blood examination, complete urine examination, and X-ray chest. Treatment in acute adenoiditis: antibiotics, analgesics, and nasal decongestant drops may be prescribed. In chronic adenoiditis, the treatment is adenoidectomy. Adenoidectomy. Adenoidectomy is the surgical removal of the adenoids by performing adenoidectomy. The indications for adenoidectomy are chronic adenoiditis, obstructive sleep apnea syndrome, supraotitis media due to adenoids, recurrent acute supraotitis media due to adenoids, and sometimes chronic supraotitis media due to adenoids. Contraindications for adenoidectomy are acute adenoiditis, cleft palate, bleeding disorder, recent upper respiratory infection. And the complications which may occur in adenoidectomy are: number one, hemorrhage, which may be primary hemorrhage due to adenoid tag present in the nasopharynx. Secondly, secondary hemorrhage, which may occur after 5 to 7 days after surgery, and this secondary hemorrhage is usually due to infection. Then, during adenoidectomy, the surgeon may cause trauma to the surrounding structures, for example, trauma to the eustachian tube, trauma to the soft palate, and sometimes cervical spine may be injured, leading to subluxation or dislocation of the atlantoaxial joint. Then rhinolalia aperta may sometimes may result due to adenoidectomy. There are certain differences between adenoids and tonsils. These are very important. Number one is adenoids. They are located in the nasopharynx, whereas tonsils means palatine tonsils. They are located in the oropharynx. Adenoids is lined by ciliated columnar epithelium, whereas tonsils they are lined by stratified squamous epithelium. Adenoids, they do not have capsule, so recurrence is possible after surgical removal. The tonsils, they are lined by capsule on the lateral surface. We have no crypts in the adenoids, but crypts are seen in the tonsils on the medial surface. Adenoids are non-paired, whereas tonsils are paired structure. Similarly, the adenoids, they undergo regression spontaneously at about 12 to 14 years of age, whereas there is no such regression is seen spontaneously in case of palatine tonsils. This is a photograph showing you different sorts of clinical features of adenoids. A patient Similar patient having adenoids. Again, similarly, a boy having features of adenoids. High arch palate is seen in this photograph. This is the X-ray soft tissue nasopharynx lateral view showing you a soft tissue shadow in the nasopharynx causing obliteration of the airway in the nasopharynx. This is the adenoid cured with GARD. This is the patient who is being operated for adenoids. This is a figure showing you how the adenoid curate is used during adenoidectomy procedure. This is the adenoid tissue which is being measured by with the help of a ruler. Thank you so much.